clear.
All right. Good morning,
Sarah,
everyone.
can you hear me?
Ebony, we can hear you. Can you hear us? Ebony, we can hear you, and you might be back on mute. So hopefully you can hear us. You're back on mute, so hopefully you can hear us as well. Good morning, everyone, and welcome to the October Oregon Health Policy Board meeting. We'll go ahead and get started in just a second. Madeline, would you be so kind to stop sharing your screen just for a second? All right. So yeah, welcome to the October Oregon Health Policy Board meeting. Excited to be able to introduce a couple of new faces to this work. One of the first things I'd actually like to do this morning is welcome our newest board member, Melina Moran, who is joining us as a official board member for the first time this morning. So a few of us had the opportunity to welcome Melina on Friday and just have a very casual conversation, getting to know her, and a few of us were able to introduce ourselves to her as well. So really excited to have you join the board, Melina. Melina brings more than 2 decades of experience working in the medical field. Melina, would you like to introduce, would you like to say a few words?
I would. Thank you. Good morning, all, and thank you for the welcome. A little bit about me. I've been in the medical field for 20 years. I was a RN at OHSU in the emergency department, and then I was a flight nurse with Life Flight. I went back to school for my master's, became a nurse practitioner. I've been a nurse practitioner for 4 years, working in primary care and currently addiction medicine. I'm also working on my doctorate in nursing practice. I'll be done early next year. And I have a passion for health equity, and that's what brings me to this board. Thank you.
Great. Well, thank you for joining the board, Melina. We really look forward to the great insight and contributions that you will bring to this work. All right. So a little bit of housekeeping now. The Zoom chat feature in today's meeting only allows attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host or co-host. All materials for today's meetings are available on the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. Let's go ahead and do roll call. Will you help me out with that, Tara, please?
Yes, happy to do so. So before I go through the full list, I'll just share that we have 3 members with excused absences today. That's Brenda Johnson, Sandy Sampson, and Jessica Gomez. So I'll start from the top of the list in alphabetical order. We have Oscar Arana.
Present.
Ebony Clark.
Present. Forgive me for not being on screen, fighting cold number 2 already.
Oh no. Take care. We have Bill Kramer.
Present.
Kirsten Isaacson. Okay. Melina Moran.
Present.
John Santa.
Here.
Okay, great. We have 5 members present, and that means we have quorum today.
Great. Thank you so much, Tara. And thank you for joining us, Evan, even though you're feeling a little bit under the weather. We really appreciate you being here and listening. So, all right. So for today's meeting, we'll cover a few different things. We'll get an agency update from Director Allen. We'll also hear about the redetermination work that's occurring in collaboration between OHA and DHS. We'll hear about the recent federal approval of the 1115 waiver. Then we'll take a short break. After the break, we'll get to hear public comments, and then we're going to hear a lot of updates from our committees, starting with the Behavioral Health Committee. Any questions or comments to welcome, Kristen? Thanks for joining us. We just went through roll call and introduced Melina, and then just kind of provided an update on what we're going to be discussing today. So glad you could join us. Any questions or additions or comments on the agenda for today?
Oscar.
Mhm.
Yes, John. I just thought it would be good to note, maybe everybody knows this, but Melina is in Central Oregon. If I got it correct, it's, we don't meet in person, so that geography just, I think it's important to come across. And so welcome Central Oregon to the Oregon Health Policy Board.
Thank you, John. Thank you for bringing that up. Really appreciate that. Yes, and we hope that we will maybe sometime in the future, maybe next year, we'll be able to do a meeting in person in your neck of the woods, Melina. So, all right. So then let's go ahead and have our first order of business this morning is to vote on the draft September OHPB meeting minutes. The draft minutes are listed as attachment number 1 in your board packet. Can I get a motion to approve the September meeting minutes, please?
So moved.
Thank you, Bill.
Second.
Awesome. All right. Any questions or comments on the minutes? All right. All those in favor, please say aye.
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 Anybody opposed? And anyone abstained?
This is Melina. I'll abstain.
Yes, thank you, Melina. I will go ahead and abstain also, just for the record, since I wasn't here. I did read the minutes, but I'll just go ahead and abstain for the September meeting minutes. All right, let's go ahead and turn it over to Director Allen. And it sounds like we have you working overtime today, since you'll be leading 3 presentations back to back. So what I'll probably do is, Director Allen, just kind of let you do the agency update and kind of move into the other presentations that you'll be leading after that as well.
Great, and thanks, Chair Rana, members of the board. And probably I'll take a pause to breathe between those and see if people have got specific questions for each one before we move on to the next. So a few things to update you on today. First and foremost, we have a little bit of an interim leadership change for the Health Policy and Analytics Division. As you know, Jeremy Vandehey left his last official day on the books, I think, was Friday, though he had stopped work for the agency about a week before that. In trying to identify, how to lead the division in the interim, of course, one of the challenges you face is, how do you not sort of set off a cascading set of people to fill in behind and fill in behind and fill in behind in an arena where we have a lot of work going on. You're going to hear a fair amount of that today. And so I'm very delighted that I'm able to introduce today, as an interim director for the Health Policy and Analytics Division, Ali Hassoun. He and the board chairs of PEB and OHPB, where he serves as the executive director, have graciously agreed for him to serve in the interim role. He'll be continuing to serve as the director of PEB and OHPB during that period of time. So I know he's going to be looking heavily to Trilby DeYoung, the deputy director, who's on the meeting today as always. And so I'm just very excited that Ali is going to be able to step in that role. And I thought what I might do for just a minute is turn it over to Ali and allow him to introduce himself.
Well, thank you so much, Pat, and Chair Rana, Co-Chair Isaacson. I must say it's a great honor for me personally to meet all of you, and I'm really humbled by the accomplishments of the board as well as the staff of the OHA. And for those of you that I haven't had the opportunity to meet, my name, as Pat mentioned, is Ali Hassoun, and I use he, him, his pronouns. I have worked in public service for about 24 years, and I've really truly loved every minute of it. I started my public career working for the executive department in their budget and policy office and the Department of Administrative Services, and enjoyed the chance to work on statewide policy issues, including the development of statewide biennial budgets and how the transition works with new governor's transition team, which we'll be experiencing shortly. I then had the opportunity to help bring up the Oregon Educators Benefit Board in 2007, and in the Oregon Health Insurance Exchange in 2011. And I've worked for both PEB and OEB in leadership roles since about 2012, including the last 4 as the director of the programs. And I really understand and appreciate the great challenges our healthcare system is facing right now. And I really appreciate the opportunity to solve problems with you, and starting with the continued advancement towards our goal of eliminating health inequities, which continues to be my main priority. And I hope to bring some of my background in commercial insurance and gain better visibility into where I can really help and effectuate positive change for our state. I recognize what a critical time this is with the transition to a new governor and a long legislative session ahead. And I really look forward to working with you all and meeting these challenges head on. So thank you.
Great, thanks, Ali. Ali hit on the fact that we're facing obviously a transition in the governor's office coming. That is a good segue to our plans for a permanent director for the division. It didn't seem to me that it was appropriate facing a transition like that to go get someone fully in place and not reflect the fact that there's going to be a change in administration in the governor's office, potentially in the director's office at OHA. And so our plan is to begin the recruitment soon, but basically tee that up so that we're in a position to be able to have finalists in January and make a decision that fully incorporates where we are with transition and those kinds of things, so that a new administration, to whatever degree, is able to weigh in on that hiring decision. So look for that look for that process to kick off soon. Second piece. In a minute here, I'm going to talk about the new waiver, which is really, really exciting. But we still have the current waiver, and we still have our current contracts and the current work that we're doing to implement the various priorities that you all set out in the process that we're in now. And so we want to be mindful of that. We want to be mindful of the fact that the pandemic happened along the way toward implementing what we came to know as CCO 2.0, but we're also beginning the process of what we're gonna kill the 2.0, 3.0 thing, hopefully, and talk about CCO 2025. What we really want to be able to do is begin the process now of what do the contracts that will begin in 2025 look like going forward. What's the engagement that we do? How do we engage with CCOs around those contract terms? There are some exciting new services. How will they work? All of those kinds of things as we think about 2025. And so we're going to really have to be able to hold both those concepts in our head at the same time. Third thing to talk about is COVID. You'll note COVID is now number 3 on the list, but it's still on the list. It's just not number 1 any longer. And I would say the best way to characterize things right now is that we seem to be at something of a plateau, potentially with a little bit of a trend up. That's not surprising given that school started not quite a month ago, and that's a pretty common source of community transmission. Our positivity rates have ticked back up just a little bit from where they were before. Our cases have been kind of bouncing around a pretty stable level. Of course, that's in the context of we have a significant undercount of cases based on at-home testing that generally don't get reported to us. Hospitalizations now, after a pretty extended period of decreases, seem also to have plateaued. However, they're also subject to some of the same challenges around around counts in terms of who's hospitalized. We do think we now have a better sense that there is perhaps less incidental hospitalization than we maybe thought before. When we really dig into charts and records and identify whose circumstances hospitalized them really due to COVID. And so really what we're looking toward is an eye toward the future. If you look at the most recent OHSU modeling, we are about where we should be in terms of a plateau, if not maybe even a little further decrease. I think the big concern is going to be, what do we have to look forward to in terms of a fall and winter respiratory virus season? The data coming out of the Southern Hemisphere is not real encouraging. There is a lot of flu. And so given the success of a couple of years of non-pharmaceutical interventions that have really almost virtually eliminated flu seasons over the last couple of years, their experience indicates that we could have a pretty significant flu year. And if we have a significant increase in COVID on top of that, we all know, of course, that our hospital systems are extremely stretched right now. Not due to COVID, but primarily due to COVID, but due to staffing constraints and those kinds of things. And so we could end up with some pretty dire circumstances. So the big message is, if you're eligible for a booster, you should get that booster as soon as it's available to you. We have good availability around the state for vaccine and for appointments at places like pharmacies and those kinds of things. And then you should also definitely get a flu shot this year. One in each arm for me last Saturday. So I would really encourage you to get that done, to do your part to hopefully not stress our systems. Peter Graven's forecasts really depend a lot on vaccine uptake, both boosters and flu shots. And if we're able to get good uptake, we're able to avoid I think the worst of the circumstances that we're potentially facing. Quickly, let me touch on HMPXV, human monkeypox. Similar to COVID, we seem to be in a little bit of a plateau kind of a place. We have good access to treatments and to vaccine. CDC, however, just opined that it looks like we may be at a point where it's not possible to catch this outbreak and put it back in a box, which is unfortunate. It would become something more problematic on an ongoing basis, and we're keeping a close eye on that work. With that, I'm just looking at my quick notes here. I think that's everything that I wanted to cover in terms of an update. Let me stop there and see if anyone's got questions.
Yes, Director Clark, or Director Allen, I have a quick question. So with that kind of recent forecast around HMPXV from CDC, do we have any ideas or forecasting of then what we're anticipating in Oregon specific to HMPXV?
No, I think that indication is brand new, so I don't think we've had time really to digest it and be able to deal with that.
Thank you, Director Allen. Are there other questions from other board members? A couple of comments. So I just want to welcome Ali as well to this work and to OHA. I look forward to working with you moving forward, and especially during this sort of time of transition that we're kind of experiencing with the new administration coming in next year. I do have a question, Director Allen. You mentioned the contracts, in 2025 and sort of how the board set out previous priorities. I remember these conversations, happening in 2016, 2017, something like that. I was a fairly new board member at that point, so there's a lot of things that were still, I was still kind of like learning. But I do remember that at that point, the former chair and the vice chair, Zeke and Carla, and I believe Brenda also was very involved in sort of kind of doing big community engagement. Even CCOs, I think, were involved and sort of in determining these priorities, these like, the board basically kind of created, I think it was about a dozen or so priorities, maybe just a little bit more. And they were categorized into, sort of like 3 or 4 buckets. I remember one of those buckets being about integration of systems. I think social determinants of health and health equity was one. Cost was another one. I'm wondering if it would make sense to sort of take a deep look at that work and sort of see where we've had really good success, where we've sort of stalled, and so that could help inform these conversations as we move forward.
Yeah, I think that's a great question. There were 4 broad themes to the last waiver and round of CCO contracts. Those translated your council a little low. I think there were 42 specific items that you all wanted us to translate into policy actions or contract. We tackled about the first dozen of those in the contracts that began in 2020, which of course was the beginning of the pandemic, and so there have been challenges with those. I think what we can certainly do is come back to you in November with a little bit of a sense of where we think we are on those 4 themes and those 42 elements and the initial elements in the contract, and give you a sense of the work that we have yet to do through the remainder of this waiver and contract period, and then how that helps tee up the next contract, if that makes sense, Chair Rana.
Yeah, that makes sense. Yeah, well, I'd love to see that next month. So
we can do that.
Any other questions or comments from the board for Director Allen? I do have another. Oh, go ahead, Director.
So if not, then I think the next topic up is the post-public health emergency, basically the great unwinding. If you're ready to move on to that topic.
Before we just go into that, I think there is one more question, and actually this is more of a question to sort of my fellow board members first, and then we can also hear from OHA leadership. But these conversations about transitions, transitions at the governor's office, transitions in leadership at the OHA level. I'm just curious to hear from my fellow board members about their thoughts regarding how do we continue this important work? How do we make sure we don't lose any momentum in the work that we've been building in the face of transitions? I don't know if so. It's a big question, I suppose.
I think that's a tough question and reflects a delicate balance that I would encourage us to strike of I think that there's so much important work that we can't press the pause button until until a new governor is elected and their team is in place, and then transitions happen and we go forward. So we have to keep making progress while leaving some space, I think, for new leadership to come in out of some I don't know, just the reality that a change in leadership is coming. And so leaving some space for that to happen and the inevitable changes to occur. But I would commend that, Ali, really appreciate that you are filling this interim role. And I see some strengths and opportunities in this overlap between your role with OWEB and PEB and the board, our kind of discussions and our desires to really push ourselves to be thinking more about the commercial market. And so I think that there's a delicate balance in the days ahead, and I think we should embrace the opportunities that are in front of us. And so how do we learn from Ali, and how do we cement some connections in this interim period so that we can strengthen that overlap with commercial? I'm probably kind of narrowly thinking about like, okay, Ali's our new the new Jeremy for us, and what does that mean, and how do we make the most of that? But those are my initial thoughts on a big question.
Thank you, Kristen. Bill, and then Ebony.
Thanks. I think Kirsten said it well. I think it's important for us to stay the course during this interim period, recognizing there may be some changes in priorities with the new administration. But first of all, the problems that we have in our healthcare system, access, quality, cost, and equity, are, I think, problems that all the gubernatorial candidates recognize and all the legislative candidates recognize. Some may have different solutions, but I think we can't, because the problems are so big, we need to keep moving forward with our existing agenda. A lot of the work that is done through the Oregon Health Authority and overseen by the board is based on legislation that exists. And so we're operating under legislative mandates. We also are overseeing programs that are largely federally funded and require, federal approval and federal collaboration. And many of the things we're doing are long-term. They're not kinds of things that can be easily turned off and turned on in response to a change in administration. So I think for a variety of reasons, we ought to stay the course. As Kirsten said, well, we need to recognize that there may be some changes in priorities or possibly policies with the new administration, but the problems we have are so big, and the direction we need to go is so clear, we should keep moving forward.
Thank you, Bill. Ebony.
Well said to both Kristen and Bill. I love that we're aligned this morning, and so my comments will be brief, but I just think that generally I think that we all know that it takes 3 to 5 years to really start to get momentum on strategy specific to kind of priorities. And I look forward to being able to have those conversations with the new leadership to kind of understand what their priorities will be, just like Kristen and Bill said, with the assumption that my assumption is that there's going to be through lines to what we already have laid out and what we're working to achieve. And then I think too that we also, as the Oregon Health Policy Board, have the opportunity to leverage our position, and we need to do our due diligence within also bringing forward our recommendations and perspective in terms of what we're seeing, just to support and assure full education and the new administration being fully informed as they start to bring forward their priorities, and we start looking at how do we kind of align efforts. And so the last thing I'll just say too is that regardless we have a responsibility to continue to stay the course based on what we have agreed and committed to, understanding that this work is fluid and iterative. Thank you.
Thank you, Ebony. John.
Yeah. Well, first of all, I think it's wise to that Director Allen is doing what he's doing in terms of Jeremy's position and going with a temporary solution for now, and in many respects I'm leaving that decision to the next administration. I think I went through one transition and it was in very difficult times. You know, it followed a fall where there were 5 special sessions, and clearly the state was in a bit of disarray around where it was going. And, you know, I think in that case, it was good that a new group of folks were coming in with new energy. You know, that's the way our government works. You know, that said, I think I recall a couple months ago some testimony or a presentation that you know, equity, health equity was important to some administrations and not so much to others. And you know, I hope that when it comes to an issue that high in priority, that there's an ongoing commitment in that case. That disappointed me to hear that had happened in the past. And I think there's been a lot of progress around that, and that progress deserves to continue forward. And I'd hope whoever is in charge the next time around will keep that in mind. And I suspect, given it the priority that's been for us, we'll do our best to see to it that that's the case.
Thank you, John. Any other thoughts? I really appreciate board members just kind of answering the question and engaging in this conversation. So thank you for that. Director Allen, I don't know if you have any response to what you may have heard.
Oh, just quickly, I was around state government when we had those 5 special sessions as well, and it reminded me that the more special sessions you have, the less special they get over time as things drag on. I would say that regardless of the change in administration, I can't imagine that you would be faced with a direction that says we don't care about health equity, no matter who gets elected across the board. Certainly, differences in emphasis or willingness to take risks, or those sorts of things will certainly vary with different candidates. But I think when it comes to the commitment to making sure that all Oregonians have the ability to be healthy and lead healthful lives, I can't see that being a major change. So I think the best thing to do is the same thing that I have told our staff, is keep doing your job and keep doing a good job at doing your job, and things move along. Things have got momentum, and that will tend to carry.
Thanks. Any other questions or comments before we move on from the agency update? All right, take it away.
All right, next up is redeterminations. So if we can pull up the presentation. And I ordinarily do this in partnership with Boris Paksarash, Director of ODHS. He's unable to be here today, so I'm gonna wing it a little bit alone. But we typically do this together because we really want to communicate that this really is partnership work. The actual function of operating the one system and determining eligibility is done at DHS, but this is really a joint effort of the 2 agencies, and we've really tried to reflect that in the way that we talk about this work. Next slide. So we'll give you a little bit of an update of where we are through the month of September, and then talk about community and partner work group updates. And I know you've gotten sort of the overall rundown of how this work is going on. So really do think of this as an update. Next slide. And next slide. So again, just a reminder, we'll get 60 days notice of the end of the public health emergency. Right now, it's scheduled to end in mid-October. We have not received 60 days notice, so that would lead you to believe that we're talking about, at a minimum, the PHE extending into December. Lots of talk that it would be January, and looser talk about a whole variety of dates beyond that. But what we know is we have a 60-day commitment, and we have not received one, so it's not our 60-day notice, so it's not going to end on October 13th. Next slide. So we've been working with our partners and our providers. We had our first webinar on September 20th. You can see we had 500 people, including making use of live Spanish and sign language interpretation. Just as an aside, I would say these are some skills and tools that we have picked up during the pandemic that we continue now to more broadly apply to other areas. You've got a link there and a QR code to be able to go to the partner and provider webpage. And we'll continue to respond to questions and materials that came up through October 7th. So this really is kind of a living sort of a exchange. We'll have further webinars coming up on the 18th, the 15th of November, December 13th, all at 10 o'clock in the morning. Next slide. So we previewed our partner toolkit at that September 20th webinar, informed by the community and partner work group. And that's basically got the kind of the communications materials that we're going to be using to be able to do this work. So it's emails, flyers, social media, that kind of thing, answers to questions. And this is all the early phase of redetermination work that gets people attuned to the idea that something is going to happen, that they need to do things, what those things are. We'll be launching that toolkit here in a couple of weeks across a variety of languages. Next slide. So we have begun mailing notices to people, and not a small number either, 25,000 per day that went out beginning September 26th. And this is basically, again, thinking about that staged approach and what we do pre-redetermination of how to get people to report address changes. We expect that we're going to get a ton of return mail. That's actually a good thing. That lets us know what the bad addresses are that we have and gives us the ability to then work through a variety of sources to reach out and identify good addresses for people. PH Tech is working that return mail process so they can get an outreach list back to coordinated care organizations and community partners to be able to do that work of getting addresses updated. And CMS has approved our ability to work directly with CCOs on this issue. Ordinarily, there's an arm's length requirement that keeps them out of this. I think it's a kind of a holdover of the national perspective on managed care versus our Oregon-specific CCO approach. Nevertheless, we've got approval to be able to do that work. Next slide. And next slide. So we've got the community and partner work group that is up and running. We anticipate just a few bullets of where we sit today. We anticipate finalizing recommendations on the sequencing of how renewals are going to go. We've talked about the idea that we're going to prioritize different populations, thinking about early working with those that are easiest to renew, saving for the end those who are going to be hardest to redetermine. And this really gets into the details of who exactly is in what category and how are we going to do that work. They've reviewed the partner toolkit that I talked about earlier that we'll be releasing in October. And their meeting materials are all available online at the link, and you'll be getting this presentation. Actually, there's a link to the presentation in the chat already. Next slide. And that really is our September update on the redetermination process. Be happy to answer questions about that.
Thank you, Director Allen. Any questions? Kirsten.
And thank you for the update. I was wondering if there was any more specific timeline on the the not wait on hold, but get the call back, the automatic callback system, or if that had already been implemented.
That is on the verge of being implemented. I don't think it's been implemented yet, but I don't know the answer to that specifically. So we'll find that out and get back to you.
John.
Yeah, Pat, I just wonder, is this the continuation of the emergency a large enough financial issue for the federal government that it's going to be part of the debate in December around ongoing government funding? It seems like this must be a pretty significant amount of money. So is that issue going to be in that? You follow me?
I do, and I think the challenge with funding cliffs and continuing resolution expirations is it almost doesn't matter if it's a big deal or not. It gets caught up in that, and so I do think we are keeping an eye on how those discussions work. What I don't know is the status of Medicaid as an entitlement versus other discretionary spending and how that's impacted, or whether it's impacted or not by continuing resolutions and those kinds of things. So that's a detail I think we'll want to follow up on as well. Also, just a point I forgot to make earlier, we do have a dashboard going live this month on the work that we're doing, and the data on that dashboard will be incorporated into the future updates that you get, and that'll include things like wait times and callback data and those kinds of things. So you've got some semi-real-time window into how that's going.
Director Allen, can you tell me a little bit about the community partner work group? Like who makes up that work group?
Yeah, so off the top, the community partner work group includes people who work with organizations that we partner with to do outreach and eligibility work, those kinds of things, as well as I believe the work group includes OHP members. So we've got some direct member experience as a part of that effort. I think in a previous presentation we gave you a rundown of who's on that, but we can recirculate for you who the members of that work group are.
Okay, thank you.
Mm-hmm.
Any other questions for regarding redetermination? Well, I just want to say I really appreciate all the work and thought that's going into this ahead of a pretty critical date that we know is coming at some point. So thank you.
I appreciate that. I guess I should just renew the warning that things are going to get pretty hairy, and this is going to get difficult. And people, it's when they open the doors to an arena for a concert, everybody can't get through the doors at the same time, and you can only have so many doors. So I want to make sure people know that this will be challenging when we get to the peak.
Yeah. Thank you. Do you want to move forward with the waiver presentation?
I would love to move forward with the waiver presentation. Let's go for that. All right, so we had big news. This was it last week only. Federal government announced the approval of our waiver. And there are some really incredibly powerful, important tools and investments in this waiver. I would say this is a much bigger deal waiver approval even than our last one was, and so I'd like to go through that. Next slide, please. So what we'll do is I'll talk a little bit about what are the authorities that are in the waiver. We'll talk about some funding. We'll talk a little bit about what's not in the waiver or what's still a little bit pending as we move forward, and then we'll talk about next steps. Next slide. Next slide. So just a reminder, there were 4 overarching themes to the waiver application. We wanted to ensure that people maintain their coverage. We wanted to not lose ground on the ground that we had made up during the pandemic of people getting coverage. We're now up around 96% of Oregonians covered, and we've done some exciting things like drive the uninsured rate for Black Oregonians down by half, which is a big step toward health equity. We want to improve health outcomes by addressing health-related social needs. We've got a lot to talk about there. We want to be sure that we've got smart, flexible spending to deliver those health-related social needs. And again, we've got big news there. And then we want to continue to work to create a more equitable, culturally and linguistically responsive healthcare system. Next slide. So in terms of new waiver authorities, the first really big deal is continuous enrollment for kids through age 6. So this means, again, if you think about the fact that half of all kids in Oregon are born on the Oregon Health Plan, they will remain covered on the Oregon Health Plan through their 6th birthday. This is a really significant improvement. We're the first. We in Massachusetts are the first states in the country to get this level of continuous enrollment. It means that kids won't churn on and off their health insurance coverage. They'll be able to maintain connection to their coordinated care organization, even more importantly, to their primary care providers through all their well child checks and all those kinds of episodes of care. And so this is really significant. On top of that, we're going to be able to have 2 years of continuous enrollment for everyone from age 6 on up. So that basically doubles the length of time someone is eligible for the Oregon Health Plan without needing to be redetermined. One of the things we knew, but we really saw vividly demonstrated during the pandemic, was the impact of this churn population. People who go on and off the Oregon Health Plan despite the fact that they continue to be eligible. And of course, what happens is you go off when you're eligible, typically for some kind of a reason having to do with the redetermination process around paperwork, or not identifying that something was an important piece of mail that you needed to respond to, those kinds of things. And you go off until you get seriously ill, and then you come back on. You've unfortunately avoided all of the opportunities for care and support that would keep you from getting seriously ill. And so now that that illness is worse for you in terms of your sickness, and it's worse for the system in terms of cost of care. Next slide. And I see Tara is putting a variety of resource documents in the chat as we go as well. All right, next big area is health-related social needs. This is a little bit interchangeable with social determinants of health. It's it's CMS's preferred phrase right now. I'll sometimes refer to HRSN, as you'll see in the presentation. But these services, we've kind of dabbled with these kinds of services before, around the margins with either state funds or with CCO, net above expenses, those kinds of things. This, for the very first time, makes these services Medicaid benefits for those who are eligible for those benefits. It's not for all Medicaid beneficiaries, but it's a pretty wide swath. It's targeted toward people who are experiencing homelessness or are at risk of homelessness. Youth with special health care needs, now up to age 26, which is an increase from age 19. We'll talk about that in a minute. Youth who are child welfare involved, older adults who are dual eligibles for both Medicaid and Medicare, and then adults and youth who are leaving justice involvement through corrections, local jails, youth authority, and adults leaving the state hospital. And I'm going to come back to state hospital, especially as an illustration of how powerful I think this new benefit is potentially going to be. Next slide. We also got the ability to provide these kinds of benefits to people who are experiencing extreme weather events. So basically, if you will, a climate change disaster response benefit. We'll be able to do things that we've been doing with state dollars as a Medicaid benefit. So air conditioners, air filters, I think generators for people who are on electrically powered durable medical equipment, basically around extreme weather events that are going to impact their health and safety. There are going to be some challenges with how this benefit works because it's going to require a declaration of an emergency. And so, as we learned, when it's hot isn't the best time to go out and try to buy air conditioners and install them. So we're going to have to figure out, how we manage this to avoid some of those challenges. But a huge benefit, a huge opportunity. Next slide. So when I think about these health-related social needs or HRSN benefits, they really shake out into three categories. This housing benefit is just huge. Rental assistance or temporary housing for up to 6 months. Again, let me take you back to that person discharging the state hospital, or who could discharge from the state hospital, but for the fact that they don't have stable housing. And thus it's incredibly difficult to wrap around treatments for them. Now we can we can basically make sure that that person's got first and last month's rent or other housing supports up to 6 months. We're able to make modifications like a wheelchair ramp if someone needs that sort of thing. We're able to do rental applications and do other tenancy support to prevent evictions so we don't break that linkage to housing. And then we'll be able to have navigation and case management around housing. If I think about people transitioning out of circumstances or who are homeless or who are at risk of homeless, these benefits as Medicaid benefits become a real game changer in terms of our ability to wrap other services that we're already able to provide around them. In terms of food, we've got the ability to provide community-based food resources, so facilitating SNAP applications, those kinds of things, nutrition and cooking education, fruit and vegetable prescriptions. You all know that, although that sounds kind of weird on the surface, that there's a great body of data that if you give someone a prescription for fruit and vegetables, they go and fill that prescription and you can get meaningful improvement in people's diets. I think Pacific Source in the Gorge has some great experience with this. And then finally, I already touched on the climate related payments. Next slide. So if we focus in on kids, I've already talked a little bit about the continuous enrollment element of this. We, for a very long time, have waived out of the early periodic screening, diagnosis, and treatment, or EPSDT services. That will end. We have not renewed that waiver. And in fact, we're going to kind of ramp them up even, where we not only provide those benefits, but for youth with special healthcare needs, kids will be able to qualify for those EPSDT and other services. And we'll move the age of eligibility from 19 up to age 26. So we'll be able to transition kids and young people with those challenges to young adults. And then we'll be able to provide those same HRSN benefits to these same kids as well. They'll be part of the eligible population for those forms of assistance. Next slide. We're going to have some changes to the prioritized list. The removal of the EPSDT waiver is one change. The other change is, we've had the prioritized list as a part of our waiver for something like 30 years. And if you think about, the waiver is a demonstration grant, I think we've demonstrated the heck out of the prioritized list at this stage. And so what we're going to do is move it out of the waiver and into our state plan amendment. So it really takes the form of how it's functioned for at least the last decade, which is it's our data-driven, science-based, publicly transparent statement of benefits. What are covered benefits under the Oregon Health Plan? One of the key features of the waiver as originally conceived was the ability to move the line up and down as state budget circumstances dictated. And we haven't been allowed by the federal government to do that for at least a decade. And it really doesn't function any longer in that kind of a budget setting fashion. So it really is what our statement of benefits is. Nevertheless, there's a lot of work to do to actually move this from the waiver into a state plan amendment. And so this won't go into effect until the very last year of the waiver. Next slide. And then the other huge element of this is the revival of a program called Designated State Health Programs, or DSHP. And what this is, and I'll have a chart here in just a second to kind of show you how the math works, but basically it's an investment of $1.1 billion in new federal dollars above and beyond what we're already spending in Medicaid that can go toward the youth with special healthcare needs and the health-related social needs spending. So think about those cool things we can do around rental assistance and food assistance and climate change. And there's a $1.1 billion over 5 years of new federal money to be able to spend on that. And that's at a net cost to the state, new state money of $88 million. And that doesn't come in until the 5th year of the biennium. And I've got a chart here in a minute to kind of show you some of the underlying finances of all this. Next slide. So let's talk about that funding. Next slide. First, back to DSHP and sort of at least kind of operationally how it works. These numbers are for illustration only. They don't have anything to do with any actual program numbers. But imagine that we're spending $100 on something that is a Medicaid-like benefit. So it's not currently covered by Medicaid, but it's similar to what we do in Medicaid. Probably the easiest example is behavioral health spending that the state does for people who aren't on Medicaid. And you imagine that we're spending $100 on that. With DSHP, we reduce our spending on that program to $50. And the federal government makes up the other 50. So we're still spending $100 on that program. But now we take the $50 that have been freed up of state dollars and we spend them on these new benefits. And that gets matched by $75 of new federal spending. So there's almost kind of a little bit of a double match sort of a thing going on here. But what it really does is allow you to maintain the spending that you were doing on the program and invest, in this case, $125 in new spending. And that's where this $1.1 billion in funding comes from. It's the program had gone away during the last administration. We're the first state in its waiver to be able to revive it, and it's a really exciting development. Next slide. So this is an eye chart that gives you a little bit of sense of funding, but I do want to give you just a little quick bit. The upper half is how DSHP works, and what you're really looking at is the fact that starting in 23-25, we end up with about 289 million, then 258 million, 286 million, 229 million of new federal dollars. You don't see anything show up in the state column of state general fund until the $88 million in that state fiscal year 2027 column, and so it's really backloaded towards state spending. The other area is the continuous enrollment. There is a cost to continuous enrollment in a couple of ways. One, you have more people enrolled, so you spend more money on Medicaid, and that follows the usual pattern that it does. And then for covering adults on continuous enrollment, what they required us to do was basically take a haircut on our federal match rate of 2.6% to reflect the fact that we may be covering somebody who's not actually eligible. And so that becomes a little bit of a federal budget neutrality. We think we've got good data to show that that's actually much less likely than you would think. And this haircut on the match rate does not apply to kids up through age 18. So it's really only the population that are eligible due to Affordable Care Act eligibility categories, and only over age 18. And so you can see there's a small state obligation there. And in the case of either of these expansions of eligibility, the legislature still got the opportunity as part of the budget setting and policy setting process in the next session to decide that we don't want to do these coverage expansions for whatever reason, including the cost. And so across the bottom, then you see what the total state and federal investment is specific to the waiver. There are some waiver implementation costs that are part of a policy package that are separate from this. Next slide. So we will have a legislative concept. We're going to need legislative language to be able to implement the DSHP program. We're also proposing to make some pretty significant changes to the quality incentive program. And here what we want to really be able to do is to bifurcate how we think about incentives. On the one hand, in terms of sort of downstream measures, rely on a set of standard CMS measures for health quality outcomes, but then move further upstream than we are today and move to a more community-based decision-making model for what are the upstream performance indicators that we want to incent CCOs to be able to do. Next slide. And here, I think I just really touched on what we're trying to do with metrics in terms of upstream and downstream. So let's go ahead and go to the next slide. And the next slide. So we aren't quite done with everything in the way the waiver's been approved, but there are some pending items that we've got 60 to 150 days to be able to work on. One came up at the very last minute, which was maintenance of effort. How are we held accountable to not just simply have these new federal dollars displace other state dollars and have it really be a new investment? And the initial language they gave us was really breathtakingly broad around all social spending at the state, federal, and local level. We pushed back hard on that immediately and got some immediate acknowledgement that was overreach. We've now got 90 days to work with CMS on pinning down not only what the maintenance of effort language is, but what's the base that we're talking about. And we've already got it cabined off into those 3 areas, or the 3 areas that we talked about, but particularly housing, housing and food, nutrition investments. We then have the implementation protocols. How are we going to do health-related social needs spending? There's a lot to do, both in terms of expectations at CMS as well as contract language with CCOs and changes to fee-for-service. We'll need to have an implementation plan. We'll also need a waiver evaluation plan, which has been typical for all of our waivers. Next slide. And then we've got some things that we're basically still negotiating with them. You've heard a presentation about the community investment collaboratives. We have not got that pinned down yet, and there is still back and forth that we expect to take over the next 90 or 120 days, maybe a little bit more. We have a set of tribal related requests that we anticipate being approved, but we've not been able to finalize them yet. And then we're still haggling, if you will, over pre-release coverage for both justice-involved individuals and people coming out of the state hospital. We've got approval in hand now to be able to cover them with health-related social needs. So back to those housing vouchers, kind of, or housing supports kind of a structure. What we're really trying to do, though, is get an extended actual 90 days of somewhat limited OHP benefits for people prior to their coming out of these settings, to be able to do a better job of bridging people's coverage over. Next slide. So there are some things that are not in this waiver. With the first 3 bullets, we ended up, after initial discussions with CMS, pulling from our requests. This had to do with rate setting flexibilities for CCOs, the ability to have something that looked more like a global budget. That's something that when you say global budget in Washington, D.C., they think block grants and run the other direction. And so all these years along, we do not actually technically have global budgets as a part of Medicaid, but we're beginning to be able to move closer as we begin to move spending upstream. We pulled our request for pharmacy flexibilities and then also expedited enrollment for SNAP. Employment and transportation benefits, and then covering peer-delivered behavioral health services, I think are still out there. Particularly peer services, we determined we could simply do through a state plan amendment, and so we'll be able to move forward with that. Next slide. This then is sort of a calendar of what's coming. You're getting a presentation. Actually, you're getting a presentation on the 3rd rather than the 4th. But you can see how we've kind of laid out who all is getting what as we move through about the next month or so of beginning to spin this work up. Next slide. I think. Oh, calendar. So this does not all go into effect at the same time. And the media has struggled mightily with that concept. So let me take another shot at explaining how this is going to work. EPSDT benefits will begin in January 2023. That's an immediate change, and we're working right now to get that program up and running. Continuous enrollment will begin as soon as the public health emergency ends, because everybody already has continuous enrollment right now while we're in the emergency. We don't know when that is, but we'll assume that it's sometime in 2023. But there's speculation of even potentially longer out there. We will spend most of 23 getting ready to deliver the rest of the waiver in 24. That means we'll be doing an implementation plan. It means that we'll be working on contract modifications for the existing CCO contracts to cover the new benefits and funding that are available. We'll need to figure out how we're going to deliver the health-related social needs benefits. All of that work will occur during 23 and will begin in 24. In 25, we'll have a new CCO 5-year contract. And so part of what we're going to be doing in 23 and 24 is figuring out what's that look like. And in particular, what does procurement look like? We have a report due to the legislature some rough outline of that work, but really the range of options go from a full-blown request for applications like we did the last time, kind of all comers and whatever anybody wants to propose, all the way down to simply extending the existing contracts. And I know there's some legislative interest in doing something like that, and most likely somewhere in between where we do something that's a little more modest in terms of geography and those kinds of things, but will still be pretty broadly encompassing in terms of deliverables and outcomes, because there's so much change involved in this waiver. And then the last thing, as I indicated earlier, is the change in the prioritized list to a state plan amendment, which happens in the last year of the waiver. Next slide. And with that, I think I've just gone through a bunch of stuff and talked really fast. Let's go ahead and take down the presentation. I'd be happy to answer questions.
Thank you, Director Allen. That was a lot of information. Questions or comments from the board? John.
Well, I think first I would just express admiration for the Oregon Health Authority team and OHA leadership. I think many of us urge that this effort be a reach, and it sure does seem that way to me. And I think a lot of credit is due, and this looks to me like really brilliant health policy work. I must admit, I always struggled with how could housing and food and air conditioners be structured as a benefit. It's just very interesting to see how you all have figured that out. Second, back a bit to Oscar's observation earlier on, I remember 5 years ago coming onto the board and the objectives that the board had, and one of those was around children. And I think Governor Brown has consistently been interested and committed to children. And, this certainly seems like a very significant movement towards, universal coverage of children. And I think that really is terrific. I do have an interest in learning more about two things, and not today, and they have to do with kind of following the money, like under continuous enrollment for children. So what will happen if children who are born into Medicaid or who are in Medicaid for a while, and then their parents get employed, the incomes rise, they have access to employer-sponsored insurance, but yet the Medicaid benefit is better than the commercial benefit. But the commercial payment rate to providers is better than the Medicaid payment rate to providers. How will those dynamics work and be smoothed out? And then the second, follow the money. I think, Pat, you referred to the community investment collaboratives and all. How much money is going through the CCOs versus how much money is going through the community investment collaboratives? It sounds like that's still being negotiated. But I think a significant move on the state's part was to move resources to organizations who had a higher priority for the community and for health equity than the CCOs were able to have. And so I'm interested in that when it eventually gets sorted out. But really terrific work, and you all really did a great job on this. Thanks.
Well, thanks, John. If I could just react to a couple of those things in terms of CICs, yeah, we're still definitely haggling. But the board's definition of health equity talks about the allocation and reallocation of power and resources. And we think the really critical element of that is people actually at the table making decisions about how things get done need to be the people who are impacted by those decisions. And so that's the work that we're that's the body of work that we're trying to get through right now. The other thing, thank you for acknowledging the team. I've got to say, Jeremy and Trilby have been great leaders throughout this work. Lisa Croyce managing this process, Lori Coiner, who has done incredible work leading particularly the negotiations with CMS. As you observed, we got things out of this that I thought we would never be able to get in terms of a waiver, and we're the first state on several of these to ever have gotten them. And so they and all of the team just deserve a huge round of thanks from all of us for this work.
Kirsten.
Yeah, I'd echo, yes, they do. So many hands and brains and hearts were at work and deserve a huge round of thanks. So agree with that point for sure. I have a specific question, Director Allen, about you had the chart showing general funds and federal funds over the years, and particularly drilling in on the cost of continuous enrollment in general fund. I was wondering if we are also able to estimate the savings from continuous enrollment, whether that be on the administrative end with just processing reduction, or on the actual like provision cost of care side, and if we're able to put into perspective those general fund dollars that are the cost of continuous enrollment and how those are or are not balanced out by savings elsewhere.
Yeah, I think we have been able to notionally talk about those savings as you just outlined, in terms of kind of logically there should be those savings. I think now with the public health emergency, we sort of have our first opportunity to actually potentially look at real data around that. I don't think we have tried to do a calculation as part of the waiver application, but that's something we can go back and take a look and see if we've got something we can provide to the board that's a little more tangible than just sort of thinking logically what the savings ought to be.
Other questions or comments from board members on the waiver? I have a couple of questions, and yes, I also want to echo John's comments and Kirsten's comments and just congratulate the entire leadership at OHA and everybody who worked on the waiver application for getting us to this point. It's very exciting. So appreciate all of the hard work that went into, seeking community input and working on this. So curious to hear more about, there's some exciting stuff here that has to do with housing and sort of being able to support folks with rental assistance. I'm curious what, like the collaboration that has occurred with OHA and Oregon Housing and Community Services to ensure that this is sort of like, so that, OHA is working directly with OHCS on this effort.
Yeah, thanks. We have been working directly with them, but this is an area where we've got resources now as a Medicaid benefit to pay for housing, but we don't have the ability to, invest in what they call sticks and bricks, the actual creation of new housing. Nor should we, because that's just not anything that's appropriate for us to do. But housing and community services and lots of local partners do, and so part of our implementation planning is going to be around marrying up these efforts with other efforts so that what we can do is maximize the benefit across a variety of different payment streams. But I think what we'll be able to do is really enter a really big, new, dependable payment stream into the mix for people who are highly vulnerable and who need other services that Medicaid is well positioned to be able to deliver, thinking about addiction treatment, mental health services, those kinds of things. But our partnership with OHCS will be a key piece of that. You're exactly right.
I guess the other, oh, John, go ahead.
Yeah, your comment, Oscar, made me think. I think the day that I heard the waiver was approved, I happened to see a senator talking about federal food policy and a bill that's in DC, and making the point that federal food policy basically highly subsidizes unhealthy foods and hardly subsidizes healthy foods, like fruits and vegetables. And, from a policy point of view, it's a little bit of a, what happened here? That, the health budget is now basically paying for the errors of the food and agriculture process. And, that's kind of interesting. But it also makes me think, hopefully the farmers in Oregon who are growing food, are growing fruits and vegetables, we'll see that there's another buyer out there, or another source of resources for them, and respond to that. As we've been innovative in tapping into another resource stream for fruits and vegetables. So that'll be interesting to see.
Yeah, I think, this makes me think that, we talked about implementation and how there will be challenges in terms of being able to successfully implement all of these things. So I'd be very interested in continuing to hear conversations in future meetings about how implementation is being, how implementation is going.
I think bringing you back a periodic implementation update would be a great step.
Thank you. Melina. You're on mute, Melina.
Congratulations. This is a huge win for Oregon, and the preventative care down the road is going to have such a huge impact. My question goes along with that implementation process, and particularly the justice-involved individuals and housing. I was wondering about people leaving the justice system and going into not just having rent covered, but sober living housing. I think that's really important to, stop their cycle of reincarceration. And I just want to ensure that that is considered.
Appreciate that. Thank you.
In addition to sort of like, kind of these ongoing implementation conversations, I'm particularly interested in sort of these continued negotiations with CMS that are still, sounds like they're still on the table. So maybe, for the next couple of months, kind of continuing to hear about updates regarding the community investment collaboratives and also the tribal request, just so that we can keep hearing about these topic areas.
Yeah, I don't know that we'll have much to report in November, but what we can certainly do is, as new developments come available, we can work with you to make sure we're on the agenda for those developments.
Thank you. Any other comments or questions for Director Allen? Okay, well, thanks again for all the hard work that went into the waiver application, and congratulations to the waiver team. And I think you finally get a little bit of a break from presenting, Director Allen. So speaking of breaks, we're all going to go on a brief break right now, and we'll come back in 10 minutes and move into public comments. So it's 9:50 right now. Let's come back at 10 a.m. and we'll continue with the second part of the agenda. Right, welcome back. If I can get the board to just do a little bit of a thumbs up or put your video back on, just so I know that folks are back. All right. Okay, so we're gonna get moving forward with public comment. The Oregon Health Policy Board welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with the kind of careful attention, respect, and honor that you deserve. We hold time in our meetings to hear public comments to provide a voice and perspective. Comments, however, are not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share. If that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a slide with a 2-minute timer for each presenter. We kindly ask that presenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. Board staff will communicate the next steps with each public speaker. I believe we have one person signed up, Tom Bussey. Is Tom here and ready?
Yes, I am.
Great, thank you, Tom. Go ahead and start when you're ready.
These comments are my own, although I should disclose I am a member of the Libertarian Party of Oregon Public Policy Board. Regulatory capture is alive and well at the Oregon Wealth Authority. I want to remind you that the Oregon Health Cost Trends Report singles out hepatitis C direct-acting antivirals as the leading driver of Oregon healthcare cost increases. The Cochrane Collaboratives found no evidence for clinical benefit of these toxic poisons that put bodies into coffins because they were evaluated on the basis of an invalid surrogate marker. In 2017, Merck, via its fake advocacy group, ALSD, delivered an ultimatum to the PT committee that if Oregon didn't cover the drugs, Oregon would lose its 1115 waiver. The bearer of this message was OHSU Dr. Atif Zaman, who just happened to be a peer reviewer of the Oregon State Drug Review. Merck rewarded Dr. Zaman in the form of $375,000 to conduct a seeding trial with 430B bad actor Central City Concern. It has been proven that Merck has used seeding trials to promote its toxin Vioxx, which killed 500,000 Americans. A seeding trial is a fake, unethical clinical trial used to pay kickbacks to physicians in the form of research requiring no or little work and having no legitimate research interests. They are illegal under OIG regulations. In the case of Central City Concern's seeding trial used to reward Dr. Zaman, the protocol involved charging the Oregon Health Plan the full amount of the robo-prescribed drugs targeting vulnerable active injecting homeless drug users. These were charged to the Oregon Health Authority in the form of payments billed to their 430B pharmacy. Also, Dr. Zaman sits on the ECHO program for continuing education for Oregon doctors. There is corruption here and nobody's doing anything about it. Thank you.
Thank you, Tom. Tara, do we have anybody else signed up for public testimony?
That is the only person that we had. If anyone else wishes to provide comment, they can certainly raise their hand or send me a message now and they could go. But that was it.
Okay, great, thank you. All right, next up is we're going to get an update on the Behavioral Health Committee from lead staff member Mireya Williams. Take it away, Mireya.
Great, thank you. Good morning, everyone. Can you all hear me okay? Great.
Yes.
Thank you. Good morning, everyone. My name is Mireya Williams. I am the Behavioral Health Committee Manager. I'm happy to be here with you this morning. She, her, ella are my pronouns. I have a PowerPoint or presentation for you all to just review just our path for our Behavioral Health Committee and where we are and where we're going. Next slide, please. So as some of you are aware, our legislative topics for this bill is we are charged, House Bill 2086, excuse me, charges us with the task of developing metrics for quality metrics for CCOs, government entities, providers, and local agencies as well. We are also tasked with ensuring that as we develop those metrics, that we also incentivize to improve the quality of behavioral health care services. And by doing that, we want to improve physical and behavioral health care integration, timely access to behavioral health care. We want to ensure that individuals are supported in the least restrictive environment that meets their behavioral health needs, reduce hospitalizations, and reduce overdoses. So those are the 5 topics that were in House Bill 2086 that we are charged with developing quality metrics for. Next slide, please. So part of our task is also, not part of our task, I'm sorry. Our Behavioral Health Committee has representation from a variety of individuals that are providers and communities with lived experience. And that may not have the understanding of how to develop a metric. What does that look like? How do we fit it into the 5 topics that we have within the bill? So our intent and our goal is to kind of slow things down a little bit so that we are able to bring folks along that may not have that level of understanding or comprehension around how a metric is developed. And so what we want to do, what you'll see here is just a pathway of these topics. So we would like to have, week 1 of an introduction on the topic at hand, just sharing what the topic is, what do we know about the topic, what additional information may be needed about the topic, and then begin some group discussions to really share from the lived experiences and professional experiences that we have in the space as we share. The second week is really to continue with the discussions, let people have some time to think about what we brought forth the first week, what questions they may have when we meet the second week, what things we may have missed, and what additional information is needed. With these discussions, it's always, our goal to ensure that we are centering equity in these discussions, that we are centering the voices of those with lived experience and those that have not had a voice at the table in our, just in current systems. And then part of our week 2 discussion is also identifying whose voices we may be missing. There's always something that we discover along the way in terms of who we might be missing, who is not represented, and who would be of value to our collective group. And then week 3 is really providing a synthesis of the topics that the 2 weeks prior discussion, combining that information, bringing it back again. Here's the synthesized version of what we heard you say. Is there anything that we missed? Are there things that maybe we didn't capture in terms of, did we capture it in the essence and the spirit that you wanted? So that we can ensure that we continue to weave and modify and adjust as needed based on the comments or recommendations or questions from committee members. And so that's kind of what our pathway looks like for our discussion moving forward. Next slide, please. So as we have those discussions, we've had, as you may see on the dates that are reflected, we've discussed improving physical and behavioral healthcare integration and timely access. Next week, we will be bringing the synthesized information from our improved timely access discussions from September 12th and September 26th to share with the group. We are also just very grateful to have our health policy analytics team work hand in hand with us and assist us in navigating how we collectively come up with concept metrics develop metrics, excuse me, but also assist the members in that what does a concept or a metric concept look like? And then, the kind of the pathway or the length of time that it takes once the creation of a metric has been completed. It's the evolution of a metric, I guess, is the best way to describe it. And so we'll be having that conversation on the 10th and gathering additional feedback from our members on the two topics of that we've discussed previously. And so part of our conversation on the 24th is to really bring some of those examples or samples of what a metric concept creation looks like based on the information that they've shared from the last two discussion topics. And just bringing some questions or just, as I mentioned, just sharing some examples or samples of what metric concept development can look like so folks can start to see, but then also having a deeper discussion with regards to, how once the concept is created, then what happens to that metric concept? And then how do we circle back to find out where it is in its being accepted, where it is in its creation, where it is in, how we implement, and then circling back to, how long it takes to measure and to really establish a baseline for that metric development. Next slide, please. And then we will continue our discussion with our next topics that are on our legislative bill, which is ensuring individuals are supported in the least restrictive environment, reduce hospitalizations, and reduce overdoses. With the same pathway in mind in terms of 1 week, we bring information, we share information, we discuss, we identify where folks are at with the topic so that we can continue to weave in what's missing as we move forward. I also just want to share that, as I mentioned, in equity work and centering the voices of individuals who haven't had the opportunity to be represented or to have a voice, it takes time to do that. And so when I have this pathway, I just want us to be aware that, sometimes discussions may need to be expanded. And so we may not finish, or we may have a good conversation that is happening near the end of the meeting that may need to pick up, that we may need to pick up the following week. And so that's part of just, leading with the voices that are represented on our committee and are also, we're not moving forward just to move forward with that intentionality in mind of bringing people along if there is that lack of understanding or additional questions are needed or additional information is needed as well. And so that is what our pathway looks like. I also wanted to share with you, because as we continue this work in creating these concepts, it's important for us to continue to center equity. And how can we do that, again, intentionally? And so I'm going to pause and ask questions and see if we can have the equity tool pulled up as I pause to see if anyone has any questions. Yes. Oh, I'm sorry, Oscar, go ahead.
Go ahead, Bill.
Thanks for this great presentation and very thorough and systematic approach to developing these metrics. I think I may have asked this at a previous board meeting, but maybe you could remind me what the answer was. I'm particularly interested in what folks in the measurement community would call outcome measures in terms of actual improvements in mental or behavioral health presentation. In other words, is there improvement in the patient's health status? I didn't see that in the list of categories. Could you comment a little bit about whether that is one of the things that your committee will be looking at?
Thank you, Bill. Yes, I think that is, the piece that I think we haven't explored as deeply is, who is the person that is impacted, right? And so it's the individual that is coming in to receive those services. So really, part of that, part of those discussions and really fleshing out what part of the system are we looking at? Because the other piece is just that it's so huge. There's so many points of entry, points of exit. We're talking about from birth to end of life in terms of just what we're looking at, youth and intersectionalities in a variety of different ways. And so that's part of what we can lead in our discussion in terms of, thinking about who is impacted by whatever we're trying to fix here, or we're trying to change or modify or adjust. And so it's always centering the individual and having that person-centered approach to that. I think we all have different labels, right? Is it a customer? Is it a patient? Is it a recipient? So really looking at it from that patient perspective.
Yeah, I think that's very good. What I would hope the committee would do, whether it's part of its formal charge or not, is to look at, are there actual improvements in health status of the people who receive care or who need care? Access to care is a good thing. Integration of behavioral and physical health is a good thing. And some of the other outcome measures in terms of, for instance, reducing overdoses are very good. But I would hope that there's a way we could incorporate improvements in health, the health status of people who need care is included some way, even if it doesn't, even if it's not called out explicitly in one of those categories. Thanks for your good work on this.
Thank you. I agree.
Thanks, Bill. Any other questions for Mireya before she moves into the equity tool? Okay, go ahead, Mireya.
Thank you. So this equity tool I put together, it centers essentially what the committee worked on in terms of what their aspirational statement was. They created their aspirational statement together as a committee, also their goals, values, and principles, and at the forefront, of course, leading with our OHA, OHPB health equity definition. And so if we pose these questions at every turn or every junction of what we're in our development of these metric concepts, it'll assist us with really leading with equity and ensuring that we are transforming or innovating the system in a different way that will help individuals who maybe have not had access, or maybe have access or have insurance, but maybe aren't accessing the system for various reasons. And so looking at, does this address the equitable distribution or redistribution of resources and power? Does this address reconciling, recognizing, and rectifying historical and contemporary injustices? And with their aspirational statement, we want to think about, does this minimize suffering and maximize well-being, possibility, and potential? I think that kind of speaks a little bit to what you were referencing, Bill, to a piece of it. And then does this promote and support individual and community agency and connections? Does this assure that racial and cultural practices of healing and thriving are incorporated? And does this thoroughly, thoughtfully, and sustainably remove barriers so that people live their lives with hope and dignity? And then their goals, values, and principles, just drew out some questions from what they had developed in those values, goals, and principles. And again, centering on equity. Does this center the person's needs and goals? And does this prioritize health equity? Does this differentiate and innovate beyond the current system? Does this advance system change? And does this transform behavioral health? And so those are, some questions that we just need to continue to keep in the forefront as we navigate and do our metric concept development and have our discussion topics as we move along. I also just wanted to mention real briefly that the committee also had an additional topics that they had developed together, and so how we infuse those into these 5 concepts is the next step of our work together as well. So those concepts, may be able to fit into the 5 that the legislature has set forth for us. And in the tabs, there's some tabs in the tool as well. So it shows the organ health, OHA and OHPB. It shows the definition, and it's all stated in there, and it also gives a visual of the aspirational statement that they developed along with the values and principles, so that we're always referencing and reflecting on those. And that is all I have, unless there's questions. Thank you so much for your time.
Thank you, Mira, for the presentation. Questions or comments from board members?
Oh, Oscar, can you hear me?
Yes, we can hear you, Ebony.
Yeah, I was wondering if maybe you can talk a little bit about just some of the challenges and feedback that you have received from the committee members, and I think it's important to make sure that we're covering some of the challenges that y'all are having to also navigate and consider, and then again, just, I know that, I don't know if you can restate kind of when was the implementation of this, and my perspective is that we're kind of in a relaunching with, new leadership, but I don't know if you can maybe just talk to some of the challenges that have also kind of impacted and are being considered as this work is moving forward.
Yes, of course. Thank you, Ebony. Thank you for bringing that forward, because I meant to mention that, and so a couple of things that are happening right now as well is that we are in the process of recruiting additional members. We've lost a few members on our committee for various reasons that they've shared with us, and so we are in the process of recruiting additional members. We also have had a few challenges or setbacks with regards to just the, as I mentioned to you all earlier, there is a balance of representation within the committee, and there's the wanting to move fast, or wanting to go fast to ensure that we're accomplishing something, or that we have a deliverable, that we have a deliverable, sorry. And so that is part of what we're trying to navigate right now, is balancing the voices of individuals who have had voice and have always been able to share their experience, or be able to share that things are not working for them, or that they want to move quicker, And then we also have individuals, as I mentioned, that really want to understand the steps along the way and really want to get to know each other and really want to understand and be a part of something that is new, something that is innovative, and something that is going to create a better Oregon for ourselves and for our future. And so we're trying to balance all of those elements as we move, through this process. Our goal is that our October work session is an opportunity for us to really, bring people along, share information, ask where people are at, in terms of their understanding of the work that we're doing and where we're going and how we're navigating this space, and then how long it takes, right? It takes, once you create a metric concept, what's the length of time to really get to that baseline information that we're wanting. And so it does take a few years for us to get our baseline data. But I think, once we get a deliverable in October, November, and again, I say October 24th is our day, but if we need additional time, then we may need to continue the discussion on November 7th as well. And so those are all of the dynamics that we're kind of moving through and figuring out how we can collectively do this work together. Does that help, Ebony?
Yeah, no, that helps. And, I think everyone knows that I'm the board liaison for that group, and I'll just be frank that essentially one of the narratives that this committee is having to navigate and not be kind of tainted or pulled down by is, the narrative of another committee that has been stood up that continues to just flounder and not deliver results. And so, that's the narrative. And, I think that, that the leadership, the staff, OHA are doing a great job. But I just think it's important that, as we're getting these updates based on our charge as the Oregon Health Policy Board and how we also oversee and support the work, just making sure that we're real clear around just the challenges that the group's having to navigate, so that then we can also kind of give our perspective, advice, and support is important.
Thank you so much. I appreciate that.
Yeah, thanks, Ebony. I think, transformation takes time. So it's not like you can sort of just flip a switch and then all of a sudden this very challenging work is solved. So yeah, totally understand that these things are going to take a bit of time. And I really appreciate Mireya sort of kind of talking through what looks like a very intentional and thoughtful approach in terms of introducing, topics, allowing the committee to sort of, have time and space to think through them, and then sort of be able to process and come back and continue moving that dialogue forward. I think that's really important to ensure that the end product is something that is going to be truly useful for this work.
Thank you, Oscar. And thank you all for your time today as well.
I do have one more question. I have a question, actually. You mentioned during your presentation that you are sort of partnering with the legislative team, like OHA's legislative team, to really understand, what are some of these processes and steps. I'm curious if if you're also working with the Health Equity Committee as well, in terms of, as you're kind of moving forward with the metric development.
I had not, no, so I am making a note of that, and will ask for some assistance in how to connect with them.
Great.
Please.
Yeah, definitely. Just so that, they also have the opportunity to potentially provide any input or guidance or on the metric development. John, your hand's up.
Yeah, I mean, I think this sounds like a much more realistic and reasonable approach than I think was suggested previously. I mean, I know to some degree the field of metrics. I don't know much about mental health metrics, but I don't think what's been done in the past in terms of mental health metrics has worked well. In other words, I don't think that there's a knowledge base in mental health metrics that is so impressive that you could just bring it over and get it going. And my sense, to some degree, the legislature and other folks thought that that could be done. And I don't think that that can be done. And so using more of a ground up approach and working along through these principles is important to get to. You probably could measure something quickly, but it probably wouldn't tell you much. And or you could measure robust outcomes, but there's probably so many inputs into those outcomes that, again, you wouldn't be sure that what you did was what was causing that. So it's good to see some movement that has support and is going forward, and need to be patient, just keep moving forward, and you'll get there. I mean, we had this experience when we tried new metrics that folks said, oh, we'll never be able to work through those. Well, we did. And this seems reasonable to me.
Thanks, John. Bill?
Thanks. I did just want to follow up on John's comment and link to my earlier comment. It is a challenge, I think, in general, performance measures or quality measures in mental behavioral health are much less developed than they are for other conditions. But there are things like the PHQ-9 depression scale, which has been well tested and has been used, that I think could be considered. Maybe it's already, I'm sure the OHA staff is aware of this. That's the kind of thing that can be considered. I don't want to pose kind of what the technical solution should be here. That's an example of, there are some measures that have been used and are useful in this particular case, being able to be used both in as an aid in diagnosis, as for tracking symptoms, and to help keep track of patients' overall depression severity during the course of treatment. So I hope that's the kind of thing that those existing measures can be used and or considered and potentially used by this committee.
Thank you, Bill. Any other questions or comments from the board? I guess I have a question for both, Ebony and Mireya. So it sounds like there's this very there's a deliverable, and there's a sort of like a timeline, and that's driving like a certain urgency towards that. And what we're experiencing is that that initial deadline may have not been realistic, or may not have been conducive to the approach that is now being taken to get to this end product. I'm curious if there's, your thoughts on if there's anything that we can do as a board to sort of provide, provide any type of support to give the staff and give the committee the space it needs to create good metrics?
I think that that's a good question, and I'll just say, I probably will sound like a broken record, is that it's about getting new perspective. It's about recentering power, and so I'm a believer in that. I support kind of the current process, and at the same time, I think that I think it's important to have kind of an infrastructure that allows for some kind of built-in translation, because many of the folks at the table, including myself, for example, are not deep experts in developing metrics. And so, how do we assure that we have kind of that translator along the way, so that then we don't get to a place with a full set of recommendations or metrics, proposed metrics, and then because of the lack of kind of technical knowledge, we have to go back to the drawing board. And so, I would, assume that there's support, and even if there's a need to bring any type of consulting expertise in terms of metrics, if, OHA staff don't have the capacity, that's something that's considered. And, I know that now there's, staff at the table that do have the ability to kind of translate as we go. Medea talked about, some of our goals, when we even think about the equity piece, is aspirational. And so when I hear the term aspirational, to me, I think that sometimes that means we're never going to achieve it. And so whatever we do, I want to make sure that it's achieved. And last thing I'll just say is that I just think that we need to be transparent around the highs and the lows, where we're at, the progress we're making, and the challenges, just so that then if we can get kind of support around an extended deadline or things like that, we can do that in advance. We can be proactive versus hitting that timeline and saying, hey, looks like we're not going to make it. And then it just continues to fill that narrative. And I'm not saying it's a true narrative, but it fills that, continued narrative out there. I know I'm rambling, so thanks.
Thank you, Ebony. Kristen.
I just wanted to ditto to what Ebony just said, pointed out about making sure that there is the assistance and resources needed in metric development, because that is so hard. That was an excellent point.
Trilby.
Thank you, Oscar, and thank you to all the board members and Medea in bringing this information forward. I really appreciate these comments about how to best integrate what's really a new and transformative approach, right? And it's redistributing of power, and that Medea is working on, and appreciate so much the understanding from board members about how much time it takes to transform and to operate fresh. And wanting to let you all know that Stacy Schubert from the Metrics program, Stacy's our director of health analytics, has been working very closely with Medea. And there's a lot of conversation about, when do you bring in sort of this slew of technical information about what it takes to develop a metric. And there has been some introduction of that information and discussion about that existing system early on. And there will be, again, I know Medea is thinking about when to plug that in and when to bring in that scaffolding, and not overwhelm with technicalities about an existing system when you have some really fresh thinking coming from people with lived experience and understanding of the gaps. So very much on our minds, very much the discussion that's going on, I think, on the committee about what information should be coming in, and lots of availability to bring that information forward. So I'm feeling very encouraged and hopeful about the process moving forward, and really grateful to you, Medea, for all the leadership you've shown with the committee. So thank you for your comments here today, and thank you to the board members for the support, and Oscar particularly for calling out the connection across to the Health Equity Committee, which is something that is going to be very powerful and important for us to do.
And can I just add that, and Ebony is always a broken record, so I'm going to say this just because, you know, I think it's also important to continue to demonstrate how we value everyone's time, including the committee members, because again, it's not lost on me that we are in a workforce shortage, and many of the folks at the table are doing, you know, 2 jobs, sometimes 3. And, you know, a lot of folks also talk about, you know, the commitment and also the strain of, you know, time. And so, because a lot of these folks are working, you know, and so when they're at this table, then it's just double time. So I just want to make sure that we're also recognizing, highlighting, and calling out appreciation for the time commitment.
Yeah, thank you for calling that out, Ebony. Actually, that was one of my questions as well, you know, with the presentation that Mireya just did. There's the committee is meeting at least twice, if not 3 times a month. And you know, that's a significant amount of time commitment. And I'm also hearing about, you know, sort of turnover within the committee. And I imagine that potentially that some of the turnover is caused by the number of meetings they're being asked to participate in, potentially, right? And you know, that's not sustainable, and you'll only continue to sort of have to, like, you know, kind of do a start and stop and bring you folks in and kind of onboard them through what's been happening. So I'm curious if the committee has had conversations about, like, look, we probably have to meet less, even if it means this taking longer.
Thank you, Oscar. You know, we actually for our next meeting, we just had a discussion about this. By we, my team and I had this discussion last week about, you know, in preparation for our 2023 meeting calendar or meetings, we want to go, you know, ask the committee. I don't know how the meetings were set up. I wasn't here during that time. And so I think it would be, you know, an invitation for committee members to let us know, you know, is this day and time working for you? And if not, do you have, you know, some suggestions on frequency of meeting and time of meeting? You know, we meet on Monday mornings from 10 to noon, and sometimes depending on, you know, the area of work that you're in, you know, Mondays are not the best days to have a meeting. And so, so that is something that we're going to ask committee members. We want their vote on whether or not this time works for them. I think we've balanced that because some committee members would like to meet more frequently, although you know, the time commitment is very you know, tight. And so so I think it's, you know, giving it back to them and having them again have that voice and share with us what works best for them would be helpful.
Great. I'm glad you guys are having those conversations. Yeah, and then, you know, sort of the comment about the connection to the Health Equity Committee, I'll leave it to OHA leadership and the committee to sort of determine when the right time is, you know, and just making sure that it's not just the meeting to make sure the meeting happens, but to have the conversations at the appropriate time. So any other questions or comments for Mireya regarding the Behavioral Health Committee? All right, well, thank you so much, Mireya, for your presentation and for all your leadership with the committee. And thank you, Ebony, as well, for being a board liaison on that committee and for all your work.
Thank you. Thank you all.
All right, we are on to the next topic, which is more updates from other health policy board committees. So I'm going to turn it over to Bill to talk a little bit about the cost growth target work.
Thanks, Oscar. This is a summary of the recent work of the Sustainable Healthcare Cost Growth Target Advisory Group, to which I'm a board liaison. As you recall, this advisory group was created earlier this year, and it held its first meeting in June. Just to recap, in terms of recruitment to the committee, was very successful. The proposed slate was presented and approved by the board at the May meeting. And I think a great shout out to Sarah Bardman and others at OHA for their efforts that resulted in a large advisory group with very good representation on all key dimensions, sector, consumers and employers, as well as hospital, physician, and health plan representatives, demographics, gender, people of color, disability, LGBTQ plus and geographic diversity, expertise. And we also have at least two members who have lived experience with healthcare affordability. The group subsequently selected two co-chairs, Felicia Hagens, Political Director for SEI Local 49, and Peter Davidson, who's Senior VP or Executive VP and CFO at Pacific Source. During the third quarter, a quick update on the activities. You heard part of this at the board meeting in August. As you know, the healthcare cost trends report was published by OHA in July that showed that between 2013 and 2019, the costs in Oregon grew an average of 6.9% annually, which were faster than the national average and faster than the state targets that have been set for upcoming years. We also saw that these increases were faster than general inflation, and they far outpaced increases in per capita income and average wages. This report was a major subject of discussion at the advisory committee, first its meeting on July 19th and again at its September 9th meeting. These meetings were primarily informational. The committee members were very interested in getting a deep understanding of these healthcare cost trends. There were no decisions made by the committees at these meetings. In particular, the committee members wanted to look at Oregon's costs relative to national costs and trends. They asked for deeper dives into primary care and behavioral health cost growth. They wanted to understand better about drug costs, which are a primary driver of overall healthcare cost increases. And the committee heard presentations about Oregon's Prescription Drug Affordability Board and the Prescription Drug Price Transparency Program. As part of those discussions, also talked about opportunities to address high pharmacy costs at the state level. There's also a discussions group about how our work fit with the value-based payment compact work group, which has been underway for several years. I'll just offer a commentary. This is my commentary, not speaking on behalf of the committee. I think a key issue that we'll need to address going forward is that cost pressures on healthcare providers have led to some concerns about whether the original cost targets are achievable or what it will take to achieve those cost growth targets. But at the same time, there are increasing cost pressures on many patients and consumers. And we will need to find a way to balance those interests going forward. Looking at our next meeting, it's scheduled, I think, for November 22nd. Their possible agenda items include a further deep dive into pharmacy costs and potential initiatives to address the problem. We may do some further analysis of price versus utilization as drivers of overall cost trends. We'll also be discussing the 2023 committee work plan and begin our discussion of the cost growth target accountability mechanisms. As you know, there are escalating accountability measures that are phased in over the first 5 years, transparency and performance improvement plans, and ultimately financial penalties. That's our update on the committee's work. So we've gotten a good start. Of course, we've got a difficult task ahead. Happy to answer any questions. And I think Sarah Bardman's also on the call, could answer questions about the committee's work.
Thank you, Bill. Any questions for Bill or Sarah from the board? Well, I just want to say, oh, there you go. John, go ahead.
Yeah, Bill, you mentioned that there's interest in and folks are looking at components of the cost issues. And I'm just wondering if one of those components being looked at in more detail is in administrative costs. You know, the activity I was involved in around the Universal Healthcare Task Force, it was interesting looking at the administrative costs and what's going on there. And you know, we had a difference of opinion in the process with the actuary about you know, what was the degree of the growth of administrative costs and what were the opportunities. And I'm just wondering if there's any effort to look at what actually are administrative costs for both the delivery system and the payer side in Oregon.
Yeah, thanks, John. Great question. My impression, looking at the first few meetings and this most recent cost growth trend report that OHA published, is that there has not been a lot of attention paid to the administrative costs. I think most people recognize that it is a component of the high costs. There's enormous inefficiency in our fragmented system. I'm not sure how much it can contribute to cost growth in recent years. But the committee has not focused on it. They focused more on growth by different payer, Medicare, Medicaid, commercial, focused on drug costs, as I said, versus hospital versus physician costs, focused on particular services like primary care and behavioral health. I think it would be a good thing to take a closer look at administrative costs. Sarah may have a comment on that as well.
I do. Good morning, everyone. Sarah Bartleman, Cost Growth Target Program Manager. Bill is correct. The committee has not taken a close look at this yet, nor have we been reporting this in our work to date. However, in our next report that we plan on coming out with later this fall, one of the components of total healthcare expenditures in the way that we're measuring it is specifically net cost of private health insurance, which we can also look at for public health insurance, and that translates to the administrative costs on the payer side. So we will be specifically breaking that out and able to trend that over time as well. I think, John, what you're talking about, maybe the sort of what's driving that more on the operational side from a provider perspective, is not something that we're currently planning on reporting on, but I think it's worth more discussion.
Yeah, that would be great. I mean, it was surprising to me because I've had so many folks on the delivery system side say, you know, how much they feel oppressed by the administrative work they're being asked to do.
And I will.
And yet, you know, when it came time to kind of get a sense of the delivery system's reaction to, well, here's the potential savings that you would have and be able to devote to something else if you could get rid of this. You know, there was not surprisingly some folks, oh, we don't know if we could get rid of anything. You know, and I think it's just we have to come to some shared realization about how much is going on from an administrative point of view on both the delivery side and the payer side. And what the opportunities are there are really substantial.
I do want to say for the record, I don't want to undermine any of the conversations that we're having or any of the feedback that we've been hearing from providers in the delivery system to date about workforce and labor costs and where that's fitting in. So I don't want to say we're not looking at administrative costs and take that to interpret that we're not going to care about labor costs, because that's certainly real. And that's something that we're having a lot of conversation about. I think what you're talking about is maybe the specific savings from more consolidated administration. And we have not tapped into that conversation yet.
Right. Right. I mean, you know, I'm talking about the costs of commissions, of marketing, of information systems, of not labor. Put labor aside and just look at what's going on. You know, we unfortunately have just seen in the media health system here use a national consultant to try to advise their folks on how better to collect money. That's an administrative cost. Trying to implement strategies related to increasing collections from lower and middle income folks is an administrative cost. And we just need, there's just much more there, I think, than both the delivery system and the payers want to acknowledge.
Thank you, John. Melina?
Yeah, hi. Thank you both for your work. And if I heard right, you said that that Oregon had a 6.9% increase, which is higher than the national average. That's shocking, and I would love to learn more about where that increase is and why we are higher than the average. And then also I look forward to hearing the committee's goals for 2023 and the work plan. And I hope there's time to report back and hear those goals.
Yeah, what we may, thanks for your interest in this, Melina. What we may want to do is, since you're a brand new board member, is we might be able to hold some kind of separate briefing. I'll volunteer Sarah Bartleman as the program manager to maybe work with me, and we could sit down with you because she has lots of materials. A good starting point, though, is that OHA report that was published in July. So I would encourage you to take a look at that. We can send it to you or put it in the chat, and then follow up with any questions you might have, because there was some further analysis been presented in the recent advisory committee meetings.
That would be great. Thank you.
Great, thank you. Thank you, Bill, for the report, and thank you for helping out with the questions. Sarah, any other questions for Bill? All right, I think we're going to hear now Health Equity Committee update. Maria, are you ready to go?
I am. Thank you so much, Chair Arana, Vice Chair Isaacson, and members of the board. I'll be providing the update from the Health Equity Committee this morning on behalf of our OHPB liaison, Sandy Sampson, our chairs, Dr. Jorge Ramirez Garcia and Steve Crosby, and our OAI Director, Leanne Johnson. So you got me today in this very cold morning here in Hood River. My name is Maria Elena Castro. I use she, her, ella pronouns, and I am the Health Equity Innovation and Implementation Manager at the Equity and Inclusion Division of OHA. And I have had the honor of staffing the Health Equity Committee since 2017. So the update that I'm going to provide this morning is related to work that has been taking place at the committee since the end of the first quarter of 2022. Equity and the elimination of health inequities, as you all have pointed out this morning, requires significant transformational change. So the Health Equity understands that the Oregon Health Policy Board and its committees have significant influence in establishing guidance and policies and incentives and accountability for Oregon's health system. So ensuring that OHPD and the committees are centered in health equity requires transforming committee membership and committee practices. So the Health Equity Committee right now is working on some of those practices related to committee governance and recruitment. So we have been looking at areas where there can be some systemic improvements to facilitate an equity-centered approach to governance. Under the guidance of our committee co-chairs, the committee formed a work group tasked with drafting a new charter to update the original 2017 version. We have engaged with a consultant, Michael Anderson Nathys, who many of you may recall was a member of the Health Equity Committee and was one of the first co-chairs, and he's working with us on this work. And the reason why we are undertaking this work is because current and past co-chairs, current and past members have found that the previous charter did not accurately capture the evolving scope of the committee's work, and the language was challenging to make operational. We are making equity and health equity operational, which is not an easy task. This work requires time, as you have all pointed out this morning. So the current charter, the draft, is drawing from OHA statute, policy, and definition, but is also drawing from facilitation best practices, from equity organizations, and committee member feedback to create a dynamic document with clear practices and strategies that tie directly to our health equity goals, and that we hope could be used as a backbone for other committees to replicate. While the bulk of the document is done, and we actually provided an update to the board in August, there are a couple of items that need more development. And for that reason, the committee will have a retreat on November 1st, where we hope not only finalize the charter for OHP approval at your December 2022 meeting, but where we also would like to develop some concrete strategic goals based on the charter's vision, mission, and value statements. So included in that values work is the development of an anti-racism statement that will ground the committee's work not only in equity, but also on anti-racism. The charter's anti-racist commitment statement will build from the Health Equity Committee continual focus on addressing health inequities in all forms. As evidenced by the memo we sent to OHPB this past summer, in support of the need to have an anti-racist stance, and where the committee highlighted the need for protections for OHA and community members from racialized hate speech and abuse. In addition to the work on the charter, which has to do with making equity operational in governance, we are making equity operational in recruitment. If you recall, in the fall of 2020, the board chartered the committee membership work group to identify and provide recommendations to overcome the structural and procedural barriers that limit the recruitment and retention of diverse committee members, and those that bring health equity expertise, lived experience, and cross-cultural experience. So we have open recruitment for up to 6 seats between now and the end of 2022. So what we're doing now is making operational many of those recommendations and doing some significant work in expanding some of them. For example, the Health Equity Committee is planning on using an intersectional gap analysis tool, which uses quantitative and qualitative data to take into account the multiple intersecting identities that current committee members and applicants bring to the table, to align its membership and representation even more closely with the health equity mission, identifying not just real race, ethnicity, language, and disability, and geographic representation, but also critical lived experience and sector expertise. It's also the hope of the committee that the work that we are doing in the intersectional gap analysis tool can also be used and replicated by other committees of the board and the board itself. So as I said earlier, recruitment is now open and will close on October 17. The Health Equity Committee plans to bring the candidates slate to the board for approval at our December policy board meeting. And that is all I had to report this morning. Pending questions.
Thank you so much, Maria, for that very thorough report. Any questions or comments for Maria? Just a really quick comment. I was, reading the committee digest, and I really appreciated how thorough the information and the report was from the Health Equity Committee on the digest. So thank you for all the thought and intention that went into that report that was included on that digest. Would love to see that kind of intention and thought through out all the committee's reports. So it's just another example of how like the Health Equity Committee continues to lead the way and sort of, kind of show, just sort of like model, this work. So thank you so much for that, Maria.
Thank you, Chair Arana.
And I'd love to try to at least maybe attend a portion of your November 1st meeting. So if you can, if you wouldn't mind sending me information about, if there's a link or the location or when that's going to happen in a schedule, I'd love to see if there's if I can make some time to participate.
And we would love to have you.
Thank you. Any other questions or comments for Maria? All right, so let's go ahead. Thanks again, Maria. So now we're going to hear from Craig Anderson about the health insurance marketplace. Craig, go ahead if you're here.
I'm here. Can you hear me and see me?
Yes, we can.
Great, thank you. Good morning, everybody. My name is Craig Anderson. I am the committee liaison for the Oregon the Health Insurance Marketplace Advisory Committee, and I'm here to provide an update to the Oregon Health Policy Board. And currently I am the acting chair of the committee. And the Health Insurance Marketplace Advisory Committee is a 15-person committee. And I'm happy to let you all know that we filled our last open seat with a tribal representative. And I just wanted to give special thanks to Chicky Flowers, who does a great job with her staff in the recruiting efforts for the committee. So we're completely full at this point. The status update for the third quarter of 2022 primarily revolves around our committee meeting that was July 21st. And at this meeting, we covered the following topics. We had 2 sessions in an ongoing education series that we're doing for this committee. In the first one, Katie Button presented on the marketplace's plan management process. And that included plan certification, carrier oversight, and the public policy work that they do on plan offerings. And in the second education session, Leanne Johnson presented on the Oregon Health Authority's Equity and Inclusion Program. We also covered 2 topics related to the Medicaid redetermination process. In the first one, Vivian Levy provided an update on the Medicaid redetermination process and the coordination efforts that they're doing with the Health Insurance Marketplace Advisory Committee. And Tim Sweeney and Lindsay Hopper, who happens to be the HIMAC representative to the Bridge Plan Task Force, also provided an update on the work that's being done by the Bridge Plan Task Force. And then lastly, we covered the 2023 rate filings that the carriers had submitted in the individual market. We also had some approvals that we covered in our third quarter meeting. The first was the committee charter that was approved. We also approved our baseline work plan that will continue through 2023. And I do want to mention that when we review this work, that we're ensuring that the work is centered on health equity, which is in alignment with the Oregon Health Policy Board priority. The last thing I wanted to mention is some of the upcoming work that's going to be covered in our fourth quarter meeting. And what we'll be doing there is preparing for the 2023 open enrollment period, and also continue to track and support the Medicaid redetermination program and the work being done by the Bridge Plan Task Force. We'll also elect officers. As I mentioned in my introduction, I'm the acting chair, but we'll have official elections for both the chair and the co-chair. And then we'll also have a revision to our bylaws. So those were my formal comments. I'd be happy to answer any questions people have.
Thank you so much, Craig.
You're welcome.
Any questions for Craig? Well, thank you so much for being here and presenting, and really appreciate your leadership on the committee. So thank you.
Of course.
All right, next we have Laura McKean with the Healthcare Workforce. Laura, are you here? Why don't we'll see if Laura can join us momentarily, and while we work on that, maybe Kristen, can you give us updates on the two committees that you are a board liaison to?
Sure. I guess I'll do Health Plan Quality Metrics Committee, HPQMC first. I think this actually ties significantly into conversations that we've already had today. Just to remind people how this committee fits into our metrics conversation. This committee is sunsetting. And so when Director Allen talked about a legislative concept for the upcoming session, and we talk about our health equity metrics committee, this is the committee that is sunsetting, and part of that transition as we think about a different way that we approach metrics in our state. But they are finishing out their work, and there is a link in the report to, and actually I think the link is broken, just FYI, Tara, maybe you could put it in the chat. They do their statutorily required report to the legislature, that if you're curious and want to review what work that committee has done for the past few years, that is an excellent summary. And now they are working on kind of a lessons learned survey, I would call it, kind of taking these comments from committee members to populate a report that is meant to provide reflections and impart the knowledge to, because there are several committees that will take on some of this metric work going forward. And so how do they put onto paper kind of resources that they wish they would have started this work with, or that were very helpful along the way, and what was essential to participation in this committee. So I think hopefully that will be a valuable resource. And I did want to flag that they've also kind of identified gaps within metrics that occurred for a variety of reasons within HPQMC's work. But that they found real challenges to measure development, and that it takes time, especially when there are not off-the-shelf options to just put into place. And I think that is definitely one of the lessons learned by HPQMC as Oregon undertakes new cutting-edge areas, or as we seek to undo structures and redistribute that power and reach into new areas, there are less off-the-shelf tools to use. And so how do they take everything that they learned over the years and share that with the committees who will do this work going forward? And I think one, I can't remember who said it earlier this meeting, but someone said transformation takes time. And it is hard, and that we take that time to transform in the face of urgent challenges as well. And so how do we make sure that we stick to that transformation? So that is how HPQMC is doing. We'll finish out the year, and really appreciate the effort that is going into this lessons learned report and the conversations at those committees. Kind of companion committee to the Health Plan Quality Metrics Committee is metrics and scoring. So I think of this broadly as HPQMC creates a menu of metrics and scoring then looks at that menu of metrics and pulls out which should be in the incentive program or the challenge pool, and where's the line that CCOs have to meet with those metrics. That is what metrics and scoring does. So they have already selected which metrics will be in the incentive program and challenge pool, and now are in the final stages of setting benchmarks and target and improvement targets for each specific metric. One thing that I will, and there's also a great update in our committee digest, but I think one of the challenges that I would like to bring forward for our board to be aware of, that as they do this work, so there's this statistic that I find very interesting, that for half of the quantitative measures in 2021, or for half of the quantitative measures in place, the statewide average in 2021 was already better than the benchmarks set for this year, 22, where we don't have the performance statistics yet, which is very interesting. But to put that in context, the pandemic really turned metrics upside down. We went to reporting only for a lot of them, and then made what was considered more reasonable benchmarks given circumstances. And now here we are at a point where okay, we're looking back, and it looks like statewide average, most people are meeting those, or actually no, most people meeting those would be incorrect. Let me say the statewide average is higher for many of them. And now we are in a place of saying, where should that line be for the next year? And it is hard because recovery from the pandemic is not a straight line. And so there is difficulty in saying, what is the performance that Oregonians, that patients deserve? Where should we incentivize our CCOs to land? And also, how does that lay in the reality of the ground? Because there are significant workforce shortages, and metrics rely on the workforce to implement and report on them. And so I really think that is something that that metrics and scoring committee is deeply grappling with and thinking about at present. So I find that there are lots of people doing great work. They just have new chairs who have been installed, and I think I appreciate the grappling that is happening within the two committees that I liaison to, and just to echo prior people's gratitude for all the people who serve on these committees and dedicate their time to it.
Thank you, Kristen. Questions from the board for Kristen? Well, I just want to thank you, Kristen, for serving as the vice chair to the board and also serving as the liaison on two committees. I know that is a lot of time and commitment, so I really appreciate everything that you're doing, and thank you for navigating, and supporting the committee as it sunsets its work and something new comes next. John, question.
Yeah, Kirsten, if you could, how have the new metrics, the interpreter metric, the kindergarten readiness metric, those were the trickiest metrics. I believe the weight metric was put aside, and I assume has never come back, but I'm interested in I think those are the of most interest to the board, those transformational metrics related to interpreters and kindergarten readiness. How have they fared in the last year?
Yes. The interpretive metric, I feel like I could comment on offhand. Let me just look at my chart here and see if I can not guess. Or Sarah, if you're on the call, you should pipe in because I don't want to get this wrong. Okay. The interpreter metric has been difficult to meet, I guess I would say.
Kirsten, this is Sarah. Do you want me to jump in?
Yes, because you're going to get it precisely correct.
No problem. So the interpreter metric, it is a glide path measure, and in the first couple years of the measure, CCOs have to conduct a self-assessment, and they have a point system on how they do on that self-assessment, and the idea is they're building the infrastructure. And for that measure, all CCOs but one met those infrastructural building requirements this last year. And where we're moving on for this next year is still building infrastructure, but on that glide path, it's to a place where the committee is going to set a target for folks who need interpreter services and what proportion of folks, what benchmark, what target, what Kristen was talking about, do they need to meet now for this measure for 2023. In terms of the kindergarten readiness work, there are 3 measures that are currently part of that. One is looking at preventive dental visits for young kids. Another is looking at well child visits for young kids, and those have been incentivized for a couple years now. I think what John is alluding to is a new measure which was just added around the social emotional health of young children. And you all had an educational webinar about that last year. I don't have data for you on how CCOs are doing on that particular measure because this is the first year that we've had it, but it, like the language access measure, is trying to get upstream, and it has this glide path where CCOs are doing a lot of infrastructure building right now. There is a learning collaborative sponsored by the Transformation Center, which is supporting CCOs in that work right now. But in terms of, how are CCOs meeting that measure, I cannot tell you that. I don't have that data. I can tell you that all of the CCOs are engaged in the learning collaborative.
Sarah, that's really great. I mean, I would just take the group back to that discussion about mental health metrics and see how long this takes. This takes a while. If you really are trying to change the system, this takes a while. It's great to hear that they're still out there, that they're still moving forward. And that the Transformation Center is involved when it comes to that the social emotional. I mean, that social emotional work is in some respects some overlap around behavioral health. I mean, the other thing that's been happening with these in the background for both of these is there's very substantial work going on at the CCOs and at OHA. And community-based work that's going on, I know, around the kindergarten readiness, the social emotional issue that takes people and funding, and so I suspect that's going to be the same process with those mental health measures, and it takes patience and time and folks cooperating with each other. So thank you. That's just what I wanted to check in on. Thanks.
I'll also add that there are some behavioral health metrics, but they are measured within a primary care setting. Like we have some metrics, but I think where there is a desire to go is how do we get into other delivery areas of the healthcare system, and therefore that's where. Anyway, what you said, John, is entirely true. It's going to take some time, and we're going to have to develop habits in new areas, and make sure that we get it right, which just is difficult. And even I think about the language access one, because I constantly have a knee-jerk reaction of, but it's the law. Why is this hard? Why does this have to be a metric? I will confess that every time we discuss it, I get a little incensed about it. But the fact is, we need to measure it. It's an important equity, and our measurement of it is exposing how essential and how challenging it is. And so rather than just me keep stomping my feet and being, it's the law, I think this process helps say, like, what do we need as a state, both as OHA and as the actors who are supposed to provide this access, this service to patients? What do we need to make this successful and actually getting into moving the actual numbers on the metric?
Right. I mean, one of my concerns is I think we do have a really incredible metric system, but it primarily focuses on primary care. Now you'll notice that there is dental stuff going on. That's really neat. And I think the dental folks have done a great job with that. But the mental health stuff, a lot of it is mental health in a primary care setting in terms of screening and things of that sort. And when you're talking about metrics for mental health, I mean, over in High Talk, they just did a very wonderful evaluation of the state of electronic record systems in the state. And, primary care is close to 100%. I mean, it's in the high 90s. Mental health is making progress, but I think it's around 2/3, something like that. I mean, it still has a ways to go. So this metric issue, we just need to be realistic about what can be done and how and all. So, thank you.
Great. Any other comments or questions for Kristen? All right, I'm going to circle back to the Healthcare Workforce Committee. And if Laura is not around, I think Mark might be willing to step in and
Neelam Gupta.
Oh, great. Neelam and Mark, please go ahead and provide the update.
Hi, good morning, everyone. Apologies for the delay, but just wanted to provide you with a quick update on all the exciting activity that the Healthcare Workforce Committee has been undertaking. In particular, we have been very active in our membership recruitment. We have been working with Stacy DeLeon Davis in the HPA division, as well as Terrence Saunders from the Health Systems Division in support of a really robust recruitment process. The committee is seeking to recruit and fill the committee slate back to 20 members, and we have a really exciting slate that we are going to be bringing to the November 1st meeting. In terms of our committee work, we are also quite busy working on several reports. One of them is the HB 4003 Nursing Workforce Staffing Shortage Study. That report is due to the legislature by November 15th. So there is going to be an upcoming educational webinar on the 25th of this month. And we will be coming to the November 1st board meeting for approval of that report. We are also hard at work on the evaluation of provider incentives. That is a report that comes to the board every 2 years, along with the healthcare workforce needs assessment report. There is going to be an educational webinar about the healthcare workforce needs assessment report on December 13th. We're really pleased to be contracting with the Oregon State University Department of Health Policy and Management on this really important study, given all the critical workforce challenges we've been hearing about throughout this meeting, and it seems to be a constant refrain that we are hearing so much about. And then there is also, before I forget, I would also like to mention around the House Bill 4003 nursing workforce staffing shortage study. We also have an advisory group that has been convened that has 60 members from across nursing leaders, advocates, and systems. That has been a really, really critical group that's been advising us. And we are also working on a contract with a contractor on that report, a nationally known expert out of the University of California, San Francisco campus. And then Mark, am I missing anything, or did I cover all the points?
Nothing to add. That's terrific.
Great.
Great. Thank you so much, Neelam. Any questions for Neelam or Mark? All right, great. Well, thank you. I think we will be hearing from additional committees next month. So yeah, I really appreciate the report outs from the committees we got to hear from today, and from the liaisons, and from staff and committee members as well. So appreciate us being informed of what's happening within the committees that report to the Health Policy Board. And then just another friendly reminder to Neelam's comments about the webinar on Tuesday, October 25th. So 8 a.m. we'll hear about the nursing workforce study then. And then our next meeting is going to be on Tuesday, November 1st from 8:30 to noon. All right, I guess we will be wrapping up a little bit early today, which I think folks are going to be completely fine with. So it was really nice to see you all. It was so great to have more time for board dialogue and to hear from my fellow board members. Really appreciate everything that you do and your perspective in this work. So thanks again, and thank you to OHA leadership for a great meeting. Have a good rest of your day. Bye, everyone.